Thank you for that very generous introduction. Today, we're going to be discussing the importance of preventing COVID and review the vaccines that pharmacists will be able to offer their clients and patients in their practices. Next slide. Our presenter disclosures, I'll just do it on behalf of Jen, who has relationships with commercial interests with advisory boards for Pfizer, Sanofi, and speaking engagements for a fee for doing this learning activity today. Next slide. And Michael, on behalf of Michael, he's been very active in his interests in helping many initiatives for advisory boards and speaker bureaus for many companies, and is receiving funding from several different companies, and including that today. Michael was very involved in the intellectual development for this presentation that you're about to see. Myself, I have no grants or research support at this time, although I'm open for anybody who would like to support me. And I've also been receiving honoraria and speaker bureaus for many of the vaccine companies that are listed here today, including an honorarium for today's talk. My only disclosure is that I have a patent for a product called the nose brush, which collects COVID and influenza from your nares for it to be discarded, and it's available in pharmacies. Next slide. So our learning objectives are quite specific today. We want to discuss the impact of COVID-19, of course, so that we have an idea of why our patients need it. We want to describe the role of boosters, because that's where most people are at right now, and the evidence surrounding the new bivalent boosters that are available to us. There should be just bivalent booster available to us, and develop a sort of a reply that you could give to patients and clients that you see in your pharmacies when they walk in and say, hey, do I really need this? Or what do you think about this? We're going to discuss today as a group a 30 to 60 second reply that you could have in your pharmacy. Next slide. So we're going to dig in, and we're going to talk about pediatric COVID vaccines to start with, because I'm a pediatrician. And this was a stock picture, and I want you to take a look at it and see some of the problems with this slide. And one of the problems that you would see as a learning point is that, first of all, this kid is being held up. So they're probably just at the age somewhere between 6 and 9 months, where they just learned how to sit, and this vaccine should be going in the thigh. The second point is that if it's being injected into an arm, it should probably be a 5/8 needle at this age, not a 1-inch needle. Thirdly, the needle is on a very severe angle, and it's probably just going to go into the fat of the child. These needles need to be perpendicular before they are given. The way that it's being held is correct, with the fingers on the syringe and the thumb on the plunger. That part is correct. Love the eye contact. Next slide. So since what might be new to many people who are listening is giving vaccines to infants, I just wanted to review the important aspects about giving it to infants. So between 6 and 12 months, the kids have very fat thighs, which makes the grandparents happy. But these fat thighs need to have a 1-inch needle to reach the muscle. So you may have different size needles that you're using, or you may not, but in infants, don't downsize to a 5/8 needle, which is classic. Keep it at the 1-inch needle that you use in adults in order to hit the muscle. Make sure you're going in the anterolateral aspect of the thigh so that you hit the muscle, and be sure to plunge it in perpendicularly. You would be perpendicular, you would insert, plunge, then remove. If you're giving another vaccine, like let's say they want the COVID and the flu vaccine, you could do that in your pharmacy. You could either do one in each leg, or you could keep them in the same leg 2 centimeters apart. After 12 months of age, the kids are generally walking, and we want to give them, as you would an adult, into the lateral aspect of their deltoid. And you could choose to use a 5/8 needle or a 1-inch needle for that age group. Next slide.
That's a great question for you, Dr. Moss. When you're looking at doing co-administrations in the same deltoid, I think on one of these calls you looked at if you're going to be 1 inch or 2.5 centimeters apart. Do you go laterally or do you go?
Yeah, can I share the screen?
Of course.
So
you want to share a new slide in?
No, I'll just I wanted to use my pointer, but Michael, you could probably do it. So
yeah, of course. Here,
if you're on the standing child, the one that's over 12 months, Nice.
Yeah.
So you would give, normally if there's one, it would be in the middle, but if there's two, you
Yeah.
would give one where your red dot is and one on the other side of the red dot. There, yeah. But be sure that that needle is aiming to the center so that it goes into the muscle.
So you would prefer that versus going up and down for that
Yes.
2.5. And
Yeah.
is there a reason, logic-wise, from
because the muscle is very small, and you're more likely to hit the muscle that way. But I don't think it really makes a difference. The one of the side effects that's been reported is injecting into the shoulder. So if you go vertical, your upper one there might go into the shoulder. Like right there, you're in the shoulder. I know you're just using it as an example, but that's a shoulder shot. So you'd have to go down on the slide, yeah, like there. And now the other one has to be high. You're getting very close together.
Right.
If you go up and down, I would be concerned about the upper one going into the shoulder, which is a known problem, as opposed to side.
That's great.
If that helps.
Yeah, perfect.
And I will just give a plug that I went to my pharmacy in my building yesterday and received a beautiful needle from my pharmacist, had me fill out the documentation, asked me the appropriate questions, gave a beautiful shot basically within a blink, and it was a fantastic experience.
That's great. So, love it. No, it's such an important point, and I'm glad you brought up the CERVA. So if you haven't, for the pharmacists that are listening today, CERVA was Pharmacy 5 and 5 at the University of Waterloo. Sherilyn Houle and Kelly Grinrod did a whole journal article on terms of CERVA. CERVA is one of the issues that we see from in the States. They said that pharmacists had the most amount of CERVA cases out of any of the healthcare professionals, but they administered significantly more injections than everyone else. We can't underestimate the importance of landmarking. It's that 30 seconds that can make such a huge difference. And to add to Dr. Moss's point, it's just looking at that muscle, making sure that it's injected correctly. Because if you inject too high and it's into the shoulder, it could be months that these patients will have chronic pain in this frozen shoulder type of basis, not responding to any of those analgesics. So lots of concerns from that basis. So that just those few seconds can make such a huge difference in terms of landmarking.
Can I also add, don't pinch the arm. So don't pinch the arm because it builds up a layer of fat, and you are likely going to inject it just into that fat. So you could hold the shoulder so that you have hand-eye coordination. You could put a thumb on the bone to give some counter pain before you give the shot as a distraction, but don't pinch up the fat and inject it. You can ask questions about that at the end if it's not quite clear, but don't pinch up the fat. Just hold it for hand-eye coordination with your other hand, and you could pinch the bone if you want.
That's great. Jed, I'm going to actually throw you in on the bus on this one. So what I've heard from other pharmacists is that little kids, so that 6 to 12 months, the pharmacists that have done that, it seems really kind of awkward at first, but they're a pretty easy goose to inject because they don't squirm a lot. It's those 12-month and up that tend to be a little more difficult. What has been your experience? Have you injected within the littlest ones and with a little bit older? How's that gone for you?
Yeah, so Mike, as you know, for a good part of my early career, I actually injected for a travel clinic under medical directive. So I started my career actually immunizing infants in that context. And I've historically always found that younger cohort, really prior to like 3-4 years old, is some of the easiest injections that I've ever given. Because you have parents that are used to the deal here. We're going for well baby visits and are very used to the routine immunization series. Parents typically are not as averse to really restraining that infant and ensuring that you've got a nice still spot. And you know, they're babies. They don't know what's going on. They don't have a fear response at this point in time. And, you know, with good technique and some of those pain management strategies, it can overall be a pretty good experience. And, you know, they're gonna cry for a little bit afterwards, but that's normal and typical, and it's part of the process. Where I've sort of always dreaded giving injections is that 5 to 13 cohort. Give me a happy toddler any day rather than a 7-year-old that wants to run around my pharmacy, avoiding and bargaining. And the parents have hyped them up. They're really worried about this. They've recently had their Tdap shot. They remember that shots hurt. And, you know, that fear response is more ingrained. And, you know, a lot of the times parents use a lot of those really bad strategies to try and get a child prepared for an appointment, not knowing that they're contributing to the problem. Some of those comments about, oh, this isn't going to hurt at all, or we're gonna do this afterwards, and they've been building it up all day. So I find that a lot of the time in that older cohort, that we're used to injecting because we've been giving flu shots from 5 and up for so long. And I know we felt nervous moving to 2 and up for flu shots, and now moving even lower with the COVID injections. But for me in practice, I've always found that the younger the child, and that communication with the parents is a little bit easier from my standpoint, and the actual injections process is a little bit less traumatic on everybody when it's the babies. So that's my personal experience, but it does take a little bit of familiarization. There are always nerves at first as you get used to one of those new age cohorts, especially when you're managing somebody else's child. They're precious. I'm a mother myself, so I've often tried to bring my child around to other pharmacists to allow them to do a first, toddler injection on him, because that confidence sometimes between the two of us gets built. But yeah, absolutely, those infants injections, once you get used to them, I give me a 6-month-old over a 6-year-old any day.
It's great. And that's such a good point. I think that some pharmacists, if you're nervous because you haven't done these injections before and you have a nervous child that's there, it just makes things worse. And I love the comments about that, that toddler to 13-year-old. I think that the interesting part is any one of us that have given a flu mist to a child and you put it in the first nostril and it's like, that's not going to happen to the second one. And then what do you end up doing? It's a challenge within this individual group. But I think it's such an important thing as we come into the season. We're going to see co-circulating, odds are co-circulating COVID-19 with influenza. So the importance of this co-administration is going to be a key issue. So, knowing this and feeling comfortable with it, and both of you sharing your expertise is great from that perspective. So,
Mike, I do want to get to the body of the talk, but I have some things to add to.
Of course, please. We have lots of time.
Based on my work with Annotatio, that I'd like to review at the end.
Okay, absolutely, and we'll make time. We can also do it here if you like, Dr. Moss.
No, let's do it at the end.
Okay, so we really focus, because we have Dr. Moss here today, and in the previous presentation and that I did with Peter Lynn, we actually covered a lot of that bivalent booster component. So we're going to really focus on pediatrics and the pediatric vaccines with a little bit of the NACI recommendations in terms of bivalent, just in case you missed the last webinar. So if you look at it, so I've been working within this COVID space now since it feels like the beginning of time. Children, first and foremost, Canadians have been just unbelievable in terms of our vaccine uptake. Compared to almost every other developed nation across the world, we've had one of the highest vaccine uptake for the primary series. With each subsequent booster dose, we've actually had a little bit less in terms of the overall uptake. But you can see here in the data here, is it looking at 1 dose of vaccine, 12 and up, 92.43% of Canadians. So when we hear about the minority is saying, no, I'm never going to get this vaccine, it's really, really a small portion of the overall Canadian population. But one thing is a laggard is that for the last 2 months, we've had indications for 6 months to 4 years, and we've had indications for a longer period of time from that 5 to 11-year-old. If you look at the uptake in terms of 6 months to 4 years for just that first dose, so what the parents have had 2 to 3 months to get into that visit, and only 2.47% of Canadians, that age group, 6 months to 4 years, have received that first dose. So the uptake of the vaccine within pediatrics is significantly lower than it has been within any other group. And this has been consistent across not only within Canada, consistent within the US and many other developed nations where pediatrics has not been the focus for both parents and in some respects, healthcare professionals as well. So let's take a look at it from a caregiver perspective. And I really wanted to address some of the key myths here. These are the ones that we hear over and over again for kids, is that COVID-19 is not a big deal. We don't have to worry about it in kids. You know what, if they all get infected, it's not a big deal. It's the vaccines are not effective in children is the second one that we commonly hear, and these vaccines are not safe in children. So let's go and take a look at each one of these perspectives from a pediatric basis. First and foremost, myth one, COVID is not a big deal. And regardless, if you look at COVID-19 in pediatrics, whether it's being a 6-month-old to an 11-year-old or 12-year-old versus a 65 to an 80 to 90-year-old, absolutely significance in terms of severe outcomes in that older patient is much, much higher in pediatrics. But in previous variants, so if we look at the ancestral strain, that was the first one, or if you looked at the previous variants, many of these kids were completely asymptomatic, had no symptoms whatsoever, were generally fine, recovered fairly quickly. The biggest concerns that we have is that I work with one clinician, and he calls his kids, not to their face, but he calls them little bioterrorists. They bring all of the infection to more vulnerable populations. So they bring everything home, and we're starting to see this as kids that go back to school in September. They start to bring everything home to their parents and to grandparents and get them sick from that perspective. Now, there are still some patients that will develop symptoms, and fatigue, fever, cough, pharyngitis, tachypnea, and diarrhea are very common. And I think that Dr. Moss, you had mentioned one time as well that fever is a real concern in terms of COVID-19 because some of these kids will have fever for a period of time, and that freaks parents out. Is that correct? Did I quote you correctly on that one?
Yeah, and for fever for more than 7 days might be a sign of the multi-system infection thing.
So yeah, it's definitely a concern, and these kids are feeling unwell when they get sick, so it's the last thing a lot of parents will end up wanting to having to see their kids within that space. Omicron's been a real game changer for kids, like looking at across the board, and these are some key things here. So on the right-hand side of the slide here, you're going to see that COVID-19 hospitalization rates are 5 times higher with Omicron as what they've had with Delta. Now, if you look at an individual level, people are saying, well, it's going to be great. Omicron is there because we see the severity of the disease, and so that individual patient is actually quite a bit lower than what we saw with Delta, where a lot of these patients would end up having lower respiratory, higher risk of hospitalization if they were to get the Delta variant component. Omicron actually seems to end up causing less severe outcomes for patients that are there, but one of the key concerns that are associated with it is that it's so much more infectious. So even if it causes less severe outcomes, but so many people are more sick, it increases the risk. So you can see here that the risk of hospitalization for 4 years and younger was 5 times higher during Omicron than it was during the peak of Delta. So from a pediatric standpoint, that could be an impact here as well. If you look at the burden of disease that are associated with hospitalization, this was again data from the US, looking from October 20th to September the 21st in the younger age groups. If they were hospitalized, the average length of stay was approximately 2 days. 7% of these patients developed pneumonia. 1 in 4 of these patients were actually admitted to ICU for observation and care. Invasive mechanical ventilation within these patients that were hospitalized, 6%, and ECMO was in 0.3%. So the key one I want to pull up is on the bottom of the slide. If you look at pediatrics, so unlike adults, so we look at adults, the more comorbidities a patient has, the sicker the person is, the older the patient is, the higher the risk of actually developing severe outcomes. We look at kids, yes, they're at higher risk if they have comorbidities, but of the kids that were hospitalized from 0 to 4, 63% of them, the vast majority had no underlying medical conditions. These were patients that were perfectly healthy. So it's just something to let parents know. It's like, oh, my kid's healthy, they eat well, everything is fine, but we just don't know. And I think that it's going to be a challenge to find out which one of these kids are going to be at higher risk of developing severe outcomes. As Dr. Moss mentioned, MISC, this is multi-inflammatory symptom disorder that happens in children, so MISC. It does occur in children. It's a relatively rare complication that's associated with it. This review is actually showing that after about 2 to 6 weeks after an infection, it's worth that the children with MISC sometimes have no symptoms associated with COVID-19 or relatively minimal symptoms associated with COVID-19 in this review. So this was looking at 953 cases that they had, cardiovascular, gastrointestinal being the key components with them. The key things I wanted to point out here is that if you look on the far right-hand side of the slide, is that if the children develop MISC, it's about 86% of them develop a severe course, where 14% develop a mild disease course. And fever, as Dr. Moss had mentioned, was occurring within almost 100% of those individuals with it as well. Peaks of MISC that have been occurring throughout the pandemic generally occur with peaks with COVID. So as COVID starts to go up within the community, so do the cases from a MISC that occur within pediatrics. Although it is a relatively rare complication, still can occur. Younger children were at elevated risk of severe COVID-19. So this was a review looking at hospitalized kids, and this was in Canada, looking at the median age. And if you look at that, it's 1.9 years. So it's a thought process, oh, these young kids are really not at high risk. We don't really have to worry about them. But that's not the case. And this actually confirms the data that I showed you from the previous slide from the US. Is here that 43% of these kids actually had a chronic comorbid condition. But again, 57%, more than half of these individuals did not. Things to watch out for if you look at the risk score of severe outcomes, anybody with really respiratory conditions, so asthma being one of those had severe outcomes, epilepsy, genetic disorders, obesity as being one, neurological disorders, all increase the risk of developing severe outcomes. Severe disease occurred in about 30% of COVID-19 related hospitalizations. So 1 in 3 of these kids that are being hospitalized ended up getting severe disease. most frequently amongst the youngest age groups. And this is consistent that we see sometimes in influenza. We see the U that many of you are familiar with. The younger they are, the higher the risk of severe disease, or the older they are. Whereas if you're right in the middle, you're at the lowest risk of having severe outcomes. So 48.7% we're seeing with 2 to 4 years, and we also see within adolescents at 12 to 17 years. Long COVID is one of the ones that I'm kind of concerned with, and it's kind of a funny picture. This came directly from the citation that we pulled. I don't think I'd be smiling this much if my kids had long COVID, but UK has done the most amount of information in terms of epidemiological data, and they've really linked up all of their patients. So every person that lives in the UK is actually linked up through the National Health Service, so they actually have really good epidemiological data. They found out, and they reported this earlier this year, that about 3% of the entire UK population have long COVID. So long COVID was defined as symptoms persisting from the last outbreak of COVID, lasting for more than 3 months afterwards. The most common symptom we typically end up seeing with these patients are sometimes would be cough and persistent respiratory symptoms. But the key concerns that we see are the neurological and cognitive function. So we see cognitive fatigue for patients. We see brain fog that is ending up happening. Patients will end up having headaches. We'll also see problems in terms of exercise. They're not able to function over that period of time. When they actually looked at interviewing kids and families that were associated, is that 1 in 50, so 1 in 50 primary school kids, this is from reception to year 6, so they're basically kindergarten to grade 6, and nearly 1 in 20 of secondary school kids ended up having long COVID for the most recent infection. So these are persistent symptoms for greater than 3 months. Now, I work with a long COVID specialist out of the UK, and his biggest concern is that kids at this age group, this is when they're sucking everything in. They're just sponges to everything they end up learning. And if they have this difficulty in concentration or brain fog over this period of time, we're not sure what this impact is going to end up having. And in terms of cardiovascular impact, we know that as the more infections that these kids are getting exposed to, the higher the risk of, and again, observational trials, but higher risk of developing a whole slew of cardiovascular outcomes that are associated with it. So there is something here. We're going to learn more about this as we move along in terms of the overall pandemic, but it's scary in terms of what the overall number is, because you can just look at, if you have kids, that's 1 to 1.5 kids per school class that are actually having in high school that have these long COVID type symptoms. The next myth is that the vaccines are not effective. So this is looking at the KidCove data. This is actually the mRNA 1273, which is Moderna's data in children 6 to 11. Now, 6 to 11 was approved for quite a while ago, so the studies were done pre-Omicron. So if you look at the efficacy, it's exactly what we saw with the original trials. You have placebo, where the cases just kind of go up, and then you have the vaccine where they stay static. And the way I always like what Peter Lynn describes, it's like a hockey stick. We see that slight increase for that first little bit, and then it just goes flat. Efficacy in terms of vaccine efficacy is 91.8% effective. These were 2 doses. It's a different administration than what we used here. So they did follow the exact same from the clinical trials and Moderna's approved indication, which is 2 doses, 50 micrograms given 28 days apart. As you know, in Canada, we recommend for pediatrics that we would do the first dose, and then typically waiting at least 8 weeks prior to that second dose. This was done to actually improve the immune response, so it might increase vaccine efficacy for patients, but also reduces the risk of adverse effects, really focusing on myocarditis was one of their key concerns. In terms of adverse, not effective, this was actually looking at data for the younger age group with the Moderna vaccine, the one that was recently approved. You can see from 6 to 11, it was actually using a 50 microgram dose. This one is actually using in younger age groups from anywhere from 6 months to 5 years, using a 25 microgram dose. They looked at vaccine effectiveness at 14 days post-dose. So, we need at least those 2 days after the second dose to be able to judge it. And then you're looking at the numbers and go, well, Mike, you showed me on the last slide, it was 91.8% effective or 92%. And you're showing me data that's showing this 50% effective or 31% effective or 36.8% effective. Why? Why was it not as effective in kids? And I think that really comes down to, in comparison, that the studies with the younger kids were actually done within the Omicron phase. So we know, and this is one of the reasons why we have a bivalent booster now, is that our current ancestral dosing of our vaccines were actually not nearly as effective for Omicron as they were for previous waves that we've actually seen in the past. And this is actually a really good summary of it that came out, and they looked at vaccine effectiveness. So again, observational data that was done. They looked at Omicron for the first one in the Kaiser Permanente post-dose 2. In adults of 18 years of age and older, so same thing, 14 to 16 days, 60 days post-dose 2 during the Omicron phase, they had 58,185. They found the vaccine effectiveness is about 44% against cases. So these are breakthrough cases that we would typically end up seeing, about 44%. Now, if you look at taking the same numbers for those kids during that period of time, so study 204, which is what I showed you the results here, and if you look at the vaccine effectiveness in 2 to 5 years and 6 to 23 months, the vaccine effectiveness is around the same as what we saw for adults during the same time. So when parents come up and said, I heard this only works half of the time, it doesn't do any of this component, it's the key things here is this was done during that key component of the Omicron phase, and it will offer additional protection if during that phase from the patient. So even if it's at 50% effective, this is common for influenza vaccines that we end up using, that we use it to prevent the severe outcomes. So they may still end up getting a breakthrough case, but the goal here is also to reduce the risk of severe outcomes for our patients. What about Pfizer? So Pfizer, as you may be aware, is a BNT162b2. Same thing, this was done for 5 to 11 years. So they're looking at 2 doses. This is a key differentiator between the 2 products, is that Moderna uses a 25 microgram doses for the older, 50 microgram dosing for the older age group. And what Pfizer ended up using was 10 microgram doses. So there's quite a difference between them, but you can see the overall results are very, very similar. So this is again done pre-Omicron, efficacy of this one, vaccine at the bottom, placebo at the top, big separation from what that basis are, 91% efficacy. So very, very similar to what we saw in that original study that I showed you. So both of these vaccines within those age groups, 5 to 11, 6 to 11, generally very, very effective from that basis. And we showed you the data. Efficacy is quite high and very comparable to what we would have seen with if we had approval for that 6 months to 4 years or 5 years earlier in the pandemic. They did the studies earlier. We would have saw very similar efficacy as what our observational data is actually showing. It's important to actually look at it when parents say, COVID's not really a big deal. And this is a slide that was put together from a CDC presentation. But if you look at deaths from things that we commonly already immunize against, so meningococcal disease, so we use quadrivalent vaccines for our kids in the, and it's a school-based immunization, usually grade 7, grade 8, and typically depending on the part of the country that you're joining from. Meningococcal quadrivalent, we had 8 deaths within the US. Our average deaths per year is 8 deaths. We immunize against varicella. We're looking at basically chickenpox here, 16 deaths that are associated with it, rubella, 17 deaths, rotavirus, 20 deaths that are associated with it. COVID-19 caused 86 deaths on average per year from that period of time. So you can see why, if you look at vaccines that a lot of parents are currently accepting as part of their routine immunization practices standpoint, cause significantly less morbidity and mortality than we've seen in pediatrics with COVID-19. So it's a key thing here when parents say it's not a big deal, but in comparison to a lot of the other stuff that's out there, there is a basis. And I just want to spend a second here. If we look at what's happening with polio outbreak, is one of the key concerns that I have. What's happened is that the anti-vaccine movement has really galvanized around the COVID-19 vaccine, and there's really that issue that's associated with it. And we've seen within New York, as immunization rates have dropped with polio vaccine, we're starting to see we've had 1 case of polio that's been reported, large amount of polio that's appearing within the wastewater. Concerns about this one from that standpoint, and we've seen this happen over and over again. We saw with measles, with the Disneyland thing several years ago. My concern is that, again, I'm worried about catching up on our pediatric vaccines and catching up on our adult vaccines to ensure our patients are protected, because we've seen lagging that has happened since the start of the pandemic. The last myth I just want to focus on is about safety, and I think that's a key concern for parents. So this is looking at 2 charts here. On the left-hand side, you see from 6 to 23 months. On the right-hand side is looking at 2 to 5 years. PD1 is post-dose 1, PD2 is post-dose 2. You can see the difference in terms of placebo versus active vaccine. Generally, this is very, very similar. If you're familiar with the studies that have been done in older kids and in adults, they're almost identical. Pain at the injection site is the most common thing. A little bit of swelling at the injection site is common in some patients, but most of these, as most of you are aware, 2 to 3 days post, they generally dissipate and disappear. And this is looking at systemic reactions, for different age groups. Again, this is looking at grade 1, grade 3, 6 to 23 months, and then 37 to 5 months here. It's a basis in it. And you can see irritability, crying more common within the little ones, because this, again, is a self-reported basis that are there. headache, fatigue, nausea in that 37-month to 5 years is very, very similar to what we saw within the vaccine groups in older children and within adults as well. And then finally, I wanted to spend a few minutes on myocarditis risk. This is one of the key concerns that parents will end up having associated with using any mRNA vaccines within kids, and this is consistent. So I'm going to focus first on the right-hand side. So what Moderna ended up doing is they looked at all of their vaccines in terms of their global database. This is 252 million doses of mRNA that was given, 1273 that was given worldwide. So this was really looking at 12 and above. This is the key groups that was in that basis. And they looked at what is the myocarditis risk of as a whole in comparison to what's expected. So fundamentally, if you look across the entire group, everybody within that group, no increased risk over what they expect within that group, consistent across the board. In males, 18 to 24, there was an increase in the overall risk. So we saw that the expected rate of myocarditis in this patient population is about 17.33 per 100,000 person years. It's 53.76 per 100,000 person years. So first and foremost, you want to focus on the absolute risk. Relative risk, people saying, well, that's 3 times the overall risk. In 100,000 patient years, it's a slight increase in the over number of cases. I can tell you in terms of the data that's been actually published with this one is that looking at myocarditis that is associated with COVID-19 versus myocarditis that's associated with a vaccine. Myocarditis with the vaccine, most of the patients were hospitalized. So that was more for an observational basis. Most were treated with an NSAID, and most of these patients actually were able to be discharged from that point. With the cardiologists and some of the patients some of the clinicians that I've worked with said they don't anticipate this is going to lead to a problem. Whereas myocarditis is associated with these active infections could lead to potential long-term health issues for our patients. And then on the left-hand side of the slide is this was actually done. This is a great paper that was actually published in the Journal of the American College of Cardiology. And they looked at, let's take high-risk groups. Let's take males 12 to 29 years of age. Let's say second dose. This is where all the risks tend to be second dose, not with the first dose, and unlikely with the boosters. They said that's where the risk is. We give 1 million of these males the doses. What is going to happen? What's the risk? So we focus on the risk. We're going to see potentially 39 to 47 more cases of myocarditis that are associated with it. But if you look at the benefits, it's significant in this group. Low risk in terms of outcomes from COVID-19, 560 fewer hospitalizations, 138 fewer ICU admissions, 6 fewer deaths in terms of the overall group. So the benefit risk has to be considered. And again, this is looking at 12 to 29 or 18 to 24. It seems to be the highest age groups that are associated with it. It's not something we typically see within the younger kids, although the studies haven't been powered enough to look at that basis. But it's, again, unlikely that we're going to typically end up seeing it. And I also want to mention with the bivalent boosters, as we move forward, before what we saw that Pfizer had a preferential recommendation within those groups from 12 to 30 that we would use Pfizer preferentially. If you look at that now, this bivalent booster has been launched, that has been removed. And if you read the NACI statement behind this, the reason why that's been removed is that because there is not usually seen an increase in overall risk with myocarditis with with the first booster or the third dose or the fourth dose or every subsequent dose thereafter. So that's why now you can end up using this Moderna dosing as indicated in 18 years of age and older. So Dr. Moss, NACI's come out with some recommendations for pediatrics. What are those key recommendations?
So this slide is meant to be a summary slide of what you could be doing in your pharmacy practice. And I would probably start at the bottom, and the age indications, as you could see, and you could divide it up into 6 months to 5 years, 6 to 11 years of age, and 5 to 11 years of age. And that's because the recommendations between Pfizer and Moderna, what they studied were slightly different age groups in whether they studied 5-year-olds or 6-year-olds. But as you could see, they're all a 2-dose schedule for looking at these vaccines. In a high-risk population, they would be a 3-dose schedule, but in this schedule, they're a 2-dose schedule, 8 weeks apart. And the vaccines that are recommended for pediatrics are here. So I think that's fairly straightforward based on this slide. Next. Do you want me to do this slide?
I can do it. It's fine. These are the take-home messages to that last section. Is really that COVID-19 can lead to significant impact on children. it's, as again, we want to be very cognizant here that the risk is still highest in the older patients and those with comorbidities. So those are the key focus. So you can see that in terms of our bivalent booster recommendations, long-term care patients, multiple comorbidities, patients that are immunocompromised that are at elevated risk. So you still want to let them know. But the scary things that we see here is that, yes, some of the kids that ended up actually getting really sick are the ones that have comorbid conditions, but more than half of these kids were healthy, and we just don't know why. So as parents are asking, do I really need to look at this from the basis is, you know what, it really depends. We just don't know what's going to end up happening when your kid ends up getting it. And the same thing would apply from a long COVID basis. We just don't know which patients at this point are actually developing long COVID. Omicron increased the risk of serious severe disease, so hospitalization risk as a population was much higher with Omicron versus previous waves. We don't know what the impact of long COVID is on children. We're going to be learning more, again, likely coming out of the UK, just because they're capturing a lot more of this data in terms of they'll link the schooling from that basis. One thing that came out of that observational data, just to let you know, if you want to have a talking point, again, observational data on only, not based on randomized controlled trials, but they found that if patients were given the vaccine, so unvaccinated versus vaccinated, and they developed long COVID, what they found is that there's about a 41% lower risk of developing long COVID in patients that were actually immunized versus unimmunized patients. And that's across all population, not just specifically in children. Current vaccine options are effective in reducing infection risk and severe outcomes. We saw that across all the individual trials. And COVID-19 vaccines have a acceptable safety profile. That's very similar in terms of the safety profile that we would see from other vaccines, so such as influenza and others moving forward. So co-administration with other vaccines, Dr. Moss.
So it's our wisdom and our thought that you can concurrently provide vaccines in general, and that you can concurrently provide the COVID vaccines with other vaccines specifically. So if somebody comes into your pharmacy, you can easily give them a flu shot and a COVID vaccine or any other vaccine concurrently. Just as a reminder, the only real rules are around live virus vaccines, which is chickenpox, shingles, and typhoid vaccine, along with MMR. So those vaccines are live vaccines that have different rules, but for all the other vaccines, you can give them concurrently. So someone can come into your pharmacy and receive the COVID vaccine, and they could receive the flu shot, for example. They could come in and receive the COVID vaccine and a Prevnar shot if they're over 65 and they haven't gotten one already. If they're coming in for a travel vaccine, they could get one as well. So concurrency is absolutely acceptable with the vaccine, and especially with the influenza vaccine.
Yeah, it's a great point. So I can just share, I'll add a little bit more flavor to that. So NACI came up and said, under 5, no co-administration. You have to space them out 14 days. That was a key component with it. So under 5, but the Canadian Pediatric Society is saying, what are you doing? You know what, we push for co-administration because we're going to have missed opportunities. So there is some similar to what we saw when the original vaccines came out, they were spacing out 14 days. I've got a feeling that for the kids, it's going to actually go to co-administration as well. NACI still recommends spacing, but you have to look into the context of that individual patient. From a co-administration, just to let you know, data has been pretty solid. Co-administration effectiveness, exactly the same. If you administer influenza vaccine and COVID-19 vaccine at the same time for both of those vaccines, in a small portion of the patients, they can have an increased risk and adverse effects, just to let them know. But in generally, the vast majority of patients had no increase versus getting either dose separately.
Just to add a cherry on top to the flavoring that Mike gave on my slide, let's go back one.
Yeah, for sure.
The maximum number of vaccines that you can get in a single visit is over 10,000. So the history of immunization is that you cannot give too many vaccines at one single visit, that your body would recognize and make antibodies to 2, 3, 4, 5, 6 vaccines. There has not been a vaccine in history that has interfered when another vaccine when given at the same time. So for concurrency, you can give any of the vaccines together in your pharmacy. The 2-week rule led by NACI and disagreed with by the Canadian Pediatric Society as Mike just pointed out, is just to give a window of opportunity in case there's side effects in the child group that we won't know if they're caused by the flu or COVID vaccine. From a peer perspective, pediatricians will be giving the two vaccines concurrently, flu and COVID.
That's such a great point. Jen, I'm going to bring you in. So what's the most you've given in your travel clinic? How many vaccines? What's your biggest number at the same time?
To an adult, I think we went 6. That may include the combo products like the Hep A typhoid combination vaccine. But there were people that had either no immunization history known, or were very immunization naive. This was their first big trip, and they were going all out, and they were heading to Southeast Asia for 7 months or something along the line. So yeah, you get there. But
I love it. I love it. It's like to Dr. Moss's point too, as well, and to yours, is that the limit of the vaccines that you can give somebody is the amount that they'll allow you to give them. That's the key limitation on it. It's not, any of the other components doesn't end actually being a problem. So that's great.
When a parent, as a practice point, when a parent says to me, "Oh no, I'm worried about giving 2 vaccines at once. Is it okay if I come back in a week or a month?" First, they're likely not going to come back. But secondly, I would tilt my head and I would go, "Oh, so you want to do something against recommendations. You want to do something that's never been studied and wise people recommend against. What has been recommended and we feel is comfortable is giving them at the same time. You wouldn't want to put your child at risk by giving them separately coming back a month from now, would you?" So that's a true statement, and I feel that it works very well.
And that's a good point. If you look at, we did, I'm old, right? So I remember when we did whole cell pertussis, and we look at the amount of antigens that we were injecting with whole cell pertussis versus acellular pertussis now. It's like night and day. Like whole cell pertussis has more antigens than what we expose in our vaccines than what we've done during an entire immunization series. And that's what we did forever. And so the amount that we're actually exposing the kids to in terms of antigens is actually quite low in comparison to what we saw with whole cell.
So in general, Mike's point is another good one for the anti-vax group, that we're actually giving less vaccine now than we did when sort of the adults got their vaccines. So between measles vaccine and whole cell pertussis, I received more vaccine that I'm giving to my kids now, even though they're getting a lot more protection. They're actually giving less stuff. So the recommendations for bivalent vaccine, which is what everybody's coming in for. So just to orient yourselves, when I went in to get my vaccine yesterday, I wanted to look at the vial because I was curious about this thing. And it did not say bivalent on it. And I looked at the pharmacist and he looked at me. So it says Omicron on it. So as a point of reference, these are NACI recommendations on what you would see as the Moderna Omicron vaccine, since it's the only one. NACI strongly recommends that individuals who are at increased risk of severe illness should be offered it. And they recommend that individuals 12 to 64 years of age who are not at increased risk may be offered it. The kids, and these are subtle recommendations from NACI that we have to live with. The high-risk populations that you could see on the right are older adults, long-term care facilities, and any underlying medical condition that includes asthma. It also includes obesity, but it also, and diabetes, and basically every disease that you could possibly think of. But asthma is one that people don't generally think of as a disease, but it would be in there. Adults from First Nations, in marginalized communities, and in congregate living arrangements, such as shelters, for example, or age homes. So those groups are a high risk, and they do get a recommended as a dose for sure. So basically, if I was a pharmacist, as they're coming in and asking for it, in our practice, in our office, if somebody's asking for it, we would offer it to them. Because from a qualitative perspective, that patient feels that they're at high risk for it, or their caregiver feels that their child is at high risk for it. So following from that perspective, if you wanted to ask, you could just ask if they had any other illnesses, and anything they list for you would be a high risk situation. Next slide. So this is specifically talking about the bivalent Omicron-containing vaccine, and it is authorized for groups 18 years and up. So generally, anybody who comes in 18 years of up should preferentially be offered the Omicron vaccine. And according to the pharmacists in my building, that's what they're all asking for, is the Omicron vaccine. So just to be specific about that, reminding ourselves that the Omicron vaccine is not used for primary immunization, so you would have to be sure that they'd already gotten something else, but it can be given as a booster from their primary immunization. So as a pharmacist, you do need to ask if they've got their first 2 shots to begin with. NACI recommends that it may be offered to 12 to 17 years of age who have moderately to severely immunocompromising conditions and biological or social risk factors that place them at high risk. But it is recommended wholly for people 18 years and up. Next slide.
That's great. So I have a couple of questions for you. So on another webinar we did, Dr. Moss, we looked at how you would approach the topic of bringing up vaccine with parents and looking at the COVID-19 vaccine specifically. Do you want to talk about how you would do that discussion with those patients?
So Mike and you and I talked about last time about how even to say certain words. So if you look from the evidence-based studies and wisdom, there's a big difference between starting off a conversation. So for example, if somebody came to pick up a prescription or they're asking you a question, it's an opportunity for you to interact with the patient, of course. And one evidence-based way of doing that is not to say, what do you think about a COVID vaccine today? But to say, would you like a COVID vaccine today? Being much more directive. In that sentence, you are adding your recommendation. And a pharmacist's recommendation to do something leads to a lot of weight, both with our wisdom, as we see it, and in evidence base. So the first thing to do is to give your recommendation. I see you're picking up a prescription today for your diabetes medication. Would you? I could give you a Omicron-containing booster today. Would you like to do it now? That would be sort of the conversation. After you've given them your solid recommendation, the next point to bring up in an evidence-based format would be the number of doses and the side effect. Just to let you know, there's been over 1 billion doses of these COVID vaccines being given. Moderna alone has given over 700 million doses. The vaccine has been shown to be safe in this population of all these people getting it. As a matter of fact, this vaccine has been scrutinized more than any other vaccine in history that you've had before, and it is found to be safe. Once you've gone through your health recommendation and your safety recommendation, those are the 2 rate-limiting steps for recommending the vaccine, and those would be the points that I would make. Mike has put some other points up there that, yes, it's okay for getting the vaccine with other vaccines. Just to let you know, you can get over 10,000 vaccines in a visit and your body will recognize each and every other one. So why don't you get your flu shot done today as well? I have both of them and I could give it to you now.
Yeah, we covered a lot of these actually. We went through as we were going through the presentation. So I'm going to bring Jen in for a discussion as well. So Jen, you've done like a gazillion doses of different vaccines over the time that you've been within practice. So I really want to look at it from an operation standpoint of how you've actually made it work within your pharmacy and how do you deal with things such as resistance or working within the workflow. I wanted to just see if you could share some of your expertise on that. We've got about 10 minutes, so I really want to give you the floor here to really focus on some of the things that you've done.
Yeah, I think, in looking back, one of the most important things that I found in incorporating programs like immunization into daily practice is to have an overall plan. And sometimes it takes stepping back to actually look at your plan and reevaluate if it's working for you. But ultimately, this is something that is outside of what our core dispensing activities have historically always looked like. And so when you introduce new services, having a plan for what each individual within your team is doing, whether that's, a single owner operator with maybe, a part-time cashier, and as the pharmacist, there's the disadvantage that you're only one person. You can only be one person in one place at one time. But one of the advantages of that is that you have full individual control and autonomy over the entire process and over what you say, what is communicated. So, there are both advantages and disadvantages to that sort of work format as compared to a large multi-professional, large support staff type, community type environment where you have lots of hands to pitch in and work together, but it becomes much more complex in terms of organizing who does what, who's the point person on this component of the program, are the most current recommendations and information being relayed in a easy to understand, digest, and remember way out through to my staff so that everyone is saying the same thing. People aren't getting conflicting information that perhaps turns them away from that vaccine appointment that day. And what each person within that team can take on as their role and what can they be a champion for within practice. So, when I was working in my pharmacy at the height of the, initial primary series campaign in Kingston, I had a full-time pharmacy assistant working with me, but I would bring in locum technicians and other pharmacy professionals, as well as other injectors, to help with some of the larger format type clinics that we ran to really bring it outside of my day-to-day practice, because I couldn't handle the workload of being interrupted every 10 minutes with a new person coming in, having those conversations, providing the injection. A scheduled, Q10 minutes type appointment would be ideal if I were focusing only on immunization. However, it was just not possible when I was, providing all of the other services that we run within our pharmacy. So for us, it made sense to bring it out and have designated clinic hours where I brought in other professionals and community volunteers to run larger volume, larger format clinics. With that, we delivered a webinar with OPA last week that people can refer back to for more information. But what I found most important was having real clarity of roles that could be communicated out to people who didn't normally work in my environment, where they knew they could just slide in and take on a very specific and dedicated role within that clinic. And it was very clear to them. So the onboarding and training that was required by myself was less, and people were able to fall into those roles, read up prior to, and to step in and help immediately was really, really helpful. So that kind of goes back to my big point about communication. It's having a really clear communications plan and utilizing all of your technology, all of your opportunities, all of your points of patient contact to consistently and constantly be a champion of immunization. I think that my patient population probably got very sick of hearing every new vaccine update over the course of that sort of 6 to 8 months where things were changing very rapidly. And what I found really important was being proactive with that the moment I knew something that the public was finding out either at the same time through press conferences I was, or, I maybe had a little bit of advanced knowledge through updates from our government and our advisory committees. But I tried to put it in patient-focused language so people could understand what their call to action was, what they were supposed to be doing in order to be able to access the vaccine that they wanted, needed, maybe didn't want, but felt they should be getting. And taking some time away from my practice to craft those messages and put them out as proactively as possible gave me back that time that I put in advance in spades, because we all know, we've all been there practicing in the pharmacy, and at 10:04 on a Wednesday morning, your phones start ringing and they do not stop. And you're going, okay, so there's been a press conference about a vaccine program expansion. It's very predictable that sort of outpouring of inquiry comes in. So be as proactive as you can. I know there are many instances where we had been reactive and we've had to pivot, but take a pause at that point in time and go, okay, what can I do to reduce the overall volume of this coming in, whether it's sending out mass emails through your assistant to all patients that allow you to contact them that way, whether it's putting messages on your pharmacy's website or social media, whether it's changing your answering machine message so that people that don't get through to you because the phones are ringing off the hook can listen to the message and know what they should be doing, because it's both a privilege and a curse that this many people are coming to us because of our accessibility and because of our knowledge. But when you're in times of that great overwhelm, what can your team do for you? What can your technology do for you? And based on your role in the pharmacy, what can only you do? And what are the highest priority tasks that have to be accomplished to make this a success? And find ways to prioritize that within your workflow and get support where you need it. What I found the best, it's just sort of to cap off and give a little bit of time for question and answer, was really the buy-in of the community and the goodwill that we got from what we were able to accomplish in those early days of the vaccine campaign. While it was very overwhelming, there was a high degree of support for the ways in which pharmacy teams were stepping up for their communities. And in many instances, we got a lot of grace for being able to say, you know what, your prescription is going to be ready. It's going to take us a little while. Please call them in advance in the future so that we're able to, proactively plan some of this workload, because we are very busy doing this alongside all of our day-to-day work. That sort of has fallen off in recent months, as I think everyone started to lose patience with the pandemic, and we're starting to see some of those emotions flare. But I think going back to that and remembering that when we communicate what people should be doing, expecting, and really, how they navigate the system, that's been a strong point for us. And going back to that, setting up that expectation that we're going to get you the information you need. It's going to be clear, it's going to be high quality, but that sometimes there does need to be time. So just give us that grace and that opportunity to take care of all of our patients, because we've been able to take this on successfully. But with that comes that opportunity cost. So I think people, for the most part, have overwhelmingly been supportive of that. It's just of late we haven't had as much understanding in recent months. And so the communication, I think, with all of that is key, both internally within teams and externally to patients.
Yeah, that's a lot of good points here. So let me, the three things I hear here is the involvement of the team as being one of the key components, which is so crucial for the success of the programs. And so great that you actually brought that up. The other is that I love the proactive approach that you're actually taking with your patients and actually explaining the communication. So you're prepping your patients for anything that's coming up and moving forward. And that open communication that you end up having with everybody so that they can know that they come to you for that component, and integrating within that overall workflow of trying to move it. And it's a moving target, as you mentioned multiple times here, is that what you did at the beginning is different from today, which will likely be different from you moving forward. And being that flexibility of being at what you've been able to do within practice has made such a big difference. And I really do appreciate you plugging that webinar that you ended up doing in terms of administration, because I think it's a crucial one for clinicians and pharmacists to know as well. We're right at the end. I don't have any Q&A, so I just thought we would just finish up and just, we're looking at from the basis is that COVID-19 vaccine uptake for kids is really lagging behind that in other groups. And I think that we as pharmacists can make a difference from that standpoint as well. Help out our groups to make sure that their patients are protected and that they have the most up-to-date information about what that risk is for their children. As I mentioned, young children are at higher risk of severe outcomes. And what we see, there is some risk there, not as much as we see for older adults, but it's still some risk. We want to make sure our parents know that it's not completely safe for them to get COVID-19. The vaccines are actually safe within that group. They do work within the group, very comparable to what they've done in other groups. We talked a bit about the bivalent booster. The bivalent booster offering increased in protection against the Omicron subvariants that we've seen in circulating within practice. And the key concern I have is worrying about the risk of long-term complications from previous COVID-19 infections or long COVID as being one of the key concerns. I don't have any questions. We're pretty much right on the hour, Don. I want to, before we sign off, I want to thank Dr. Moss for sharing his expertise. Hopefully you found that additional basis of just, he's done this for quite a long time working with pediatrics. It's really great to actually have that perspective. Jen, I really appreciate you sharing your operational perspective. It's helpful because you've done this so well within your practice. I want to thank Don from OPA for actually hosting us today, and Moderna for actually sponsoring pharmacist education. And to that point, I'll turn it over to you, Don.
I'd just like to say thank you and have a great day, everyone.
Thanks, everyone. Take care.
Yeah.
Thanks so much. Bye-bye now.